use this one.
Yeah, that's okay. Our next presenter is Masum Billah. He's also from the Faculty of Health, and he's going to talk to us today about his research on health promotion methods for refugees living in a regional town in New South Wales, Australia, findings from a participatory qualitative study. Thanks, Masum.
Okay, welcome again to my presentation. Presentation topic is health promotion methods for refugees living in a regional NSW city, Australia, findings from a participatory qualitative study. What I would like to tell, first of all, I already collected qualitative data from refugee participants and also conducted workshop with these findings with them. At the same time, I have prepared this research result to conduct workshops with healthcare professionals. So the same things I will be presenting to conduct a workshop with healthcare professionals. So these presentation slides are prepared for them. So the same topic I'm presenting here. So this is basically presentation related to health promotion methods or strategies, what we can revise and finalize for these communities to get them connected with Australian mainstream health system. Okay, so I will acknowledge first, I would like to acknowledge the traditional owners of the land where we work and live. We are in Gambiagir country and we acknowledge the traditional owners of this land, the Gambiagir nation, and pay our respects to Gambiagir elders, past and present. Well, this is the overview of today's presentation. I will be shedding a little light on background information first. Why I'm focusing on this area? Refugees face heaps of unique health needs and well-being inequities. At the same time, they struggle with accessing healthcare services in a very developed, industrially well-organized setting because they come from different conflict-prone regions. Sometimes they left from some sort of, war situation country. So they go through different sort of physical and mental conditions once they arrive in destination, in Australia. So they have some sort of pre-migration health conditions. Once they arrive here, they have also developed some sort of different health conditions. Altogether, they experience different health risk behaviors. So in my study, we are focusing on 4 SNAP behaviors. First of all is smoking tobacco, another one alcohol consumption, another on physical inactivity, another on unhealthy eating or unhealthy food patterns or unhealthy behavior patterns. Well, so we found lots of studies regarding refugees and they have focused on different issues. Most of the studies focuses on migration dynamics and migration related pre and post effects. But if we think of the very developed country setting, refugees have different sort of problems and health promotion interventions. We have different federal and different state governments have different sort of plan and agenda for them. But we are in a little bit confused because different health promotion interventions are not currently sufficient for reaching these hard to reach communities. So we have basically set out our goals for this study. What did we do? we basically completed a qualitative participatory study with 18 participants. Well, it might seem a little, less number of participants, but for refugees and actually for interviewing them, it's really good number for me because the refugee projects or even this sort of projects is very complex project to cover and conduct interviews with these communities. So we conducted individual in-depth interviews with 10 participants, and we conducted 2 focus group discussions with 2 different language communities. Each focus group was of 4 participants. Well, we interviewed people from Myanmar, Iraq, and Syria, and they should have 18 years and over in terms of age. At the same time, I tried to cover up male and female 50 to 50 for gender representation. At the same time, we interviewed those refugees who just arrived in Coffs Harbour and also surrounding areas. They have stayed there for maybe years and months. Strategies, what we have actually suggested for health promotion. I will be highlighting my findings on the basis of these 4 points. Quitting smoking, tobacco, reducing alcohol, drinking alcohol, increasing physical activity, improving healthy eating. These are the 4 SNAP behaviors which I focused on my thesis. Well, so this is the point where we focused on organizing group discussions, and also some of our participants preferred small group discussions because they let us know if we make or organize a big group discussion, it's sometimes difficult for these communities to get information. So we cannot organize the big group discussion. So they have restricted the group discussion. It should be small, and 3 to 5 persons are fairly enough for organizing and conveying health messages for these communities. And also, the most important thing, shortly after COVID-19, they experienced different difficulties taking some sort of, health support through online or even phoning service or mobile services, which they found a little bit another barrier to access healthcare services. So they preferred face-to-face discussion. The most fascinating part for these communities is language. And that is not only the thing, actually, they have only one lingua franca or common language. If we bring some interpreters for the same main language, that will be effective. That's not the issue. Because, for example, those who are from Myanmar, Burmese communities, they have around 15 to 16, 17, 18 languages which are different dialects. So multiple dialects are one of the major barriers to access healthcare, because whenever the existing health system hires an interpreter for a patient to interact with the health professional, we normally check and find available interpreters from, for example, Burmese language, which is the main language or lingua franca for Myanmar community. But those who are living in Coffs Harbour or even different parts of Australia, they don't have any idea about this Burmese language, because they come from the very remote and regional settings of their own country. They have their own dialects, which does not have even sometimes any writing format or any alphabetical order or any alphabets. So sometimes they don't know actually how to write it. At the same time, they experience different difficulties whenever they actually have been advised to take medicine, because they can't read English, which is difficulties. So the point is, I'm approaching here, multi-dialect puzzles is the hardest barrier for accessing healthcare for these communities. Same thing also is applied for those people who come from Iraq and Syria. They have also different dialects. Even whenever they go for Centrelink and also other supports related to health and also their financial issues, so they also experience same difficulties, which is again related with health and medicine. And these people also advised us to lead the sessions, whatever we organize for quitting smoking tobacco or reducing alcohol consumption or even for increasing physical activity, even for increasing healthy eating. We need to confirm these sessions should be led by older people, a little bit senior, because their communities do not hear to the very younger people, which really surprised me. I don't know, because sometimes maybe people do not pay attention to those actually who are very young. So sometimes they feel they are not matured enough to convey the message regarding their culture. I think it might be related with their culture and some sort of background. They have suggested they need to have all the health materials, guidelines, and also some sort of suggestions should be translated in different dialects, not only on the main language. For example, for Myanmar, they have Chin language, they have Karen language, they have, Chomin language. So each and every health, guidelines, for example, it might be related with upcoming COVID. Actually, some COVID issues are popping up in the world. So they need to have the health messages related to any sort of health issues in their own dialect, which is effective for them. At the same time, if we think of Iraq and Syria, they have different sort of dialect also. Some of them, speak in Yazidi language, which we do not have interpreters here. Even sometimes interpreters are not well equipped in terms of their excellence in interpretation. We are coming up with these things also. So for all the communities I came across, they have the different issues related with their language. Well, so next point is making video clips in multi-dialect and lingua franca. So when we presented these findings with refugee participants second time in a workshop, they advised us to make some videos for their communities, which might be more effective because some of the community people, they don't have knowledge to read something and even to understand always, watching or even following a video, it would be great for them because sometimes they cannot read. So that's why videos should be organized in such a way their language should be in their own dialect. So making video clips which are easily transferable to their mobile phones so they can watch it. Otherwise, normally they have less access to social media and sometimes they don't frequently browse YouTube also. So that's the interesting findings for us to make video clips in multi-dialect and also in their main languages. And that should be sending to their Viber, WhatsApp, like message option directly. So,
2 minutes.
Oh my God, okay. And next, they have advised to encourage mass media and social media campaigns, but these media campaigns are effective for young generation. Well, for quitting smoking tobacco and reducing alcohol use, they have advised to get counseling from doctors, especially. The doctors' counseling and suggestion might be the most effective thing for them. And at the same time, they have advised to promote messages on stopping vaping, e-cigarettes, reducing alcohol use, and basically stopping drug use for younger generation because they feel young children are much more habituated with this sort of health risk behavior, so they should have campaigns for young generation. And next thing, coordination between the government and the community. They have advised to take initiatives on behalf of the government. For example, government can impose some sort of restrictions on illegal sale of tobacco and drugs. And they have also advised to give penalty like $10, and later when I organized workshop, they advised me it should be $100. $10 is less for Australians or people who are living in Australia. So anyway, we will be discussing the same thing with the healthcare professionals, which whatever their consent about this on. And for increasing physical exercise and improving healthy eating, they have advised to conduct health professionals sessions, which, for example, for healthy eating, it might be we can call upon dietitians, nutritionists, and doctors who should have definitely interpreters in different dialects who can convey the message directly for them. And also, family doctors, gym instructors, and physiotherapists, they can lead, exercise sessions. Well, so government financing for gym facilities has been advised because sometimes people feel some sort of expensive gym opportunities for them, and also they also advised to collaborate with STARTS and Red Cross U19 for the exercise facilities. For healthy eating, they have advised to allocate lands on behalf of the government. It might be some communal or joint lands for growing some sort of vegetables, which might fill the needs of the green vegetables, because which is very costly for these communities. And also, they have been advised to encourage communities to use their backyards, and for fresh vegetables, even they can buy some pots to grow vegetables. And these are the all what I wanted to tell you. Thanks.
Thank you so much, Masum. Yeah, important work for vulnerable populations. Okay, stick around.
Yeah.
Any comments and questions for Masum? Thanks, Erin.
Thank you, Masum. I'm always really interested in any health initiatives for vulnerable populations, so it's really great work that you're doing. There was a lot of wonderful recommendations that you discussed today. I guess I'm just wondering, is there anything in particular that surprised you that came out of the data or your analysis?
Oh, okay. Okay, so I can tell you the most important thing is that actually multi-dialect issues are not seriously represented in different research, which is really surprising for me and for my supervisor also, actually language itself. And another point is that if we actually run all the promotional messages, or if we follow all the promotional methods and techniques what we are doing at the moment, it does not work for them. Because New South Wales, they have 4 or 5 programs like Fun Project, Picnic Project, and also multilingual Quit Project. So they don't hear about this one because they don't know actually these are the services which are running by New South Wales government for their betterment, but they don't have any idea, which really surprised me a lot, because before doing this sort of interview and also before planning my study, I actually talked to the health promotion officers, public health experts, and public health researchers, doctors, nurses, midwives from the New South Wales to prepare my questionnaire and other stuff. And also my research field work is funded by the Mid-North Coast Local Health District. So we had to discuss with them a lot. So they have actually put a question related to their existing services, asked them whether they are well familiar with these services. And most of them said, no, I don't know anything. No, I haven't heard about this one. No. So only one thing is START, which I talk about this one. It's a trauma services. They have heard about this one because this services is directly connected by the nurses whenever they come in Coffs Harbour and screened by the health professional here in the Coffs Harbour Hospital, and they tell the message and convey the message. So they hear about only a START project. So I will recommend NSW government and our concerned people to put it in their agenda in the nurses daily screening, so that they can get the message whenever they are in the touch base in Australian land. So that's the thing. Actually, I'm getting some sort of connection, which is really important. And also for START services, I asked them, do you take any service from START? No, I don't take any service. Why? Because it's giving us mental pressure, because they are asking our previous past sorrow events. Again, I don't want to remember those things what I have spent during my campus stay and also pre-migration conflict and war situations and different issues. So start is good. That's really appreciating for them. But the thing is that actually other services, they are not supposed to get in. So which is really one interesting point for me. And also, last point, just one sec. Just last point is that like, they have different programs, we have different programs. If you go to the transport and also media, television, YouTube, everything is that. But the thing is that they never care about all these things. That's why we are planning to make quick video clips which they can get in their mobile directly and we can direct them, please have a look, so they can have it. Yeah. So that's why they can get messages about improving healthy eating, physical activities and exercise stuff. And these findings are quite similar to other findings from my supervisor from her big project. They have found the same thing with the Australian other, Aboriginal and other communities. They're working with them. So they have also made the same videos. These are the co-designing. So my PhD is also at some points I have co-designing. So we are co-designing some sort of messages for these communities to reach them. Thank you.
Yeah, great. All right. Oh, question from Craig. You're not over yet.
No, I'm here, okay.
Yeah, thanks, Masum, for a really interesting presentation. I'm just interested in, for instance, some of the challenges that the participants might face as refugees, not as participants. But for instance, if you're focusing on improving healthy diet and you're looking at community gardens, allotments and use of backyards and stuff, I'd imagine that people from Myanmar and Iraq and Syria might be used to planting different plant crops, food crops. So is there a challenge for them in readjusting to what they plant and how they know how to look after what they're planting?
Okay, wonderful. Very interesting question, yes. Actually, they have already some sort of gardening in their homestead, but landlord does not allow to, make any gardening in their land. So that's the issue for them, but they know how to produce item. And as a multicultural people, I have different people here in the farming sector from Bangladesh. They are producing our Bangladeshi food here also. So Australia has all the nationals food, I think, either Iraq, Myanmar, they have everything. And those they have their ethnic people, they know how to make it. And even I know also, so every people know about it. I think it will not be a big deal. The issue is that these multicultural people like Burmese and Iraqi and Syrian people, they don't have own space for growing something, which is very challenging for them because they are very curious, because they come from some sort of hilly landscape, remote regional, because they are very much attached to nature, so they grow their food every time, so they know how to make it, how to nurture it. So it would be really great for them actually to leverage financial issues if they have the opportunity funding. So that's why they have raised their voices to arts for their appeal to the government to give some communal lands or joint lands that might be very effective for them. Okay, some part of me, so they can do something like this. So thanks, good question, but it's, thank you. Thank you very much for your kind support.